Good evening, colleagues. Good evening, colleagues. On behalf of AMPATH, I would like to extend a warm welcome to all of you joining us for today's session in our General Practitioner Masterclass webinar series. We are delighted to have you with us and appreciate you taking the time out of your busy schedules to engage in this learning opportunity. This series is designed to provide practical, clinically relevant insights that support everyday patient care and strengthen collaboration between clinicians and the laboratory. Today's session will focus on common questions in chemical pathology, addressing practical and frequently encountered challenges in interpreting laboratory results, an area that is highly relevant to daily clinical decision-making. It is my pleasure to introduce our speaker for today, Dr. Tanusha Reddy. Dr. Reddy is a chemical pathologist who obtained her FC-Path qualification and completed her Master of Medicine at the University of KwaZulu-Natal. She brings a strong clinical foundation with prior experience in pediatrics, as well as additional qualifications in child health and HIV management. Her professional interests include pediatrics, maternal health, HIV medicine, and innovation in laboratory medicine. Since joining AMPATH, she has been actively involved in educational initiatives and contributes to advancing laboratory practice through engagement with emerging technologies. In addition to Dr. Reddy, we have a panelist, myself, Dr. Nareshni Lachman, chemical pathologist, and we have a panel of hematologists comprising Dr. Zandre Nell, Dr. Renee Weyers, and Dr. Pete Vessels. I will now hand you over to Dr. Tanusha Reddy. Please join me in welcoming her. Dr. Reddy.
Hello, everyone. Thank you for that warm and wonderful introduction, Nareshni. Being an experienced chemical pathologist, Nareshni, you would know what the typical day in the life of the chemical pathologist starts with. It's, of course, the 3 C's. Coffee, calcium corrections, and one phone call, at least one phone call, beginning with a, "Hi, Dr. Reddy, I have a quick question," but we all know it's never a quick question, is it? Just joking. Handling queries is one of my most favorite parts of my day. Chemical pathologists are a bit like detectives, except instead of solving crimes, we solve mysteries caused by sodium levels, liver enzymes, and sometimes some very, very creative sample collections. My role today is to answer some common questions that clinicians generally ask in chemical pathology. So let's dive into my world and see where we go. One of the most famous questions is, what does a decreased eGFR mean in a healthy patient, and should I worry? GFR refers to glomerular filtration rate, and it is a key indicator of renal function. eGFR refers to that estimated glomerular filtration rate, and this is a mathematically derived entity based traditionally on a patient's serum creatinine level, age, sex, and sometimes race. This is usually calculated by AMPATH using the CKD epi equations, and a normal eGFR is more than 90 mL per minute per 1.73 meters squared. Since 2014 at AMPATH, we have been using the 2009 CKD epi equation for calculation of eGFR without applying a race correction factor in adults, that is, patients more than 18 years old. And this is in keeping with the European Renal Association guidelines, which advised against the implementation of the 2021 equation until it's locally validated. We have to understand that the updated guidelines, also coming from the NICE Institute, published in 2021, have also advocated for dropping that race change. This change has been strongly supported by the UK Kidney Association and other partner organizations. Both race and ethnicity are social constructs, and therefore assumptions about biological differences are inappropriate. While genetic, socioeconomic, and environmental factors can all plausibly contribute to differences between individuals, the broader categorization of race for the purpose of quantifying kidney function fails to recognize the extensive heterogeneity that exists within all ethnic groups. And we can understand how important that extensive heterogeneity is for a country like South Africa, where we have a beautiful rainbow nation. To note on the slide, we have the correction for body surface area, 1.73 meters squared, which is an important thing for certain patient groups. And I'm thinking about our amputees and extremes of body habitus. So, what is this EGFR used for? Estimated glomerular filtration rate is widely used for detection, diagnosis, prognosis, and management of patients with kidney diseases. GFR thresholds are a major underpinning of many clinical decisions in medicine. Amongst others, they guide medication initiation, discontinuation, and dosing, nephrologist referral, planning for dialysis, and evaluation of kidney transplantation, as well as the utilization of contrast-based tests and procedures like CT scans and cardiac catheterization. It can also be used in clinical trial eligibility and recruitment. And on a population level, it's used for surveillance and population tracking of kidney diseases. The most recent kidney disease or KDICO guidelines, the clinical practice guidelines, were actually released in 2024. And they recommend testing people at risk for chronic kidney disease using both urine albumin to creatinine ratios and the estimated GFR. Following the incidental detection of elevated albumin to creatinine ratio, hematuria, or a low GFR, repeat testing should be done to exclude acute kidney injury, or acute kidney disease. In adults at risk for CKD, creatinine-based glomerular filtration rates should be used for the initial assessment. The highest priority conditions for patients with CKD screening are your hypertensives, diabetics, CVD patients, including those with heart failure. For diabetics, the ADA and KDICO recommend annual screening of people with diabetes for CKD, starting at diagnosis of type 2 diabetes and 5 years after the onset of type 1. It is also important to do follow-up testing on patients with recurrent AKI or AKD. Other high-risk people may be identified through genetic factors by varying exposure to environmental pollution, pesticides, and nephrotoxic medications, including significant analgesic use and herbal medication. So the main thing is to use the CGA staging system. We need a cause, we need to look at the glomerular filtration rate, and we need to look at the albuminuria category for CKD. So because we need our EGFR to diagnose CKD, what are some of the important things that we should consider when we are looking at the EGFR? What are the pitfalls and what are the cautions of using this estimation? So some important things to consider are that it is only an estimate of kidney function and error is possible, most likely to be inaccurate in people of extreme body type, patients with limb amputations, severely malnourished, or morbidly obese patients. We also need to keep in mind that the 90% confident intervals are quite wide. That is, 90% of patients will have a true GFR within 30% of the estimated GFR, and 98 will have measured values within 50% of that estimated value. So, for an individual patient, it becomes very important to look at serial values because these will be much more consistent and can tell us a lot more. When looking at serial values, we have to bear in mind that if there is a huge drop, like between 20 to 25% decrease in that GFR, this could reflect an important change. We always need to look at those trends in the GFR. It is much more informative than just a once-off reading, especially for CKD. We need to look for progressive fall in the eGFR across serial measurements. That would be much more concerning, especially if you've had stable readings over time. So as we spoke about race before, there was some concern about the adjustment for ethnicity, and I have explained how our lab has overcome that. So what do we say about the not so good near normal? What does that mean? So the equations used for estimating eGFR tend to underestimate normal or near normal function. Therefore, slightly low values, example around 60 moles per minute per 1.73 meters squared, or the CKD cut that's around our CKD cutoff, should not be overinterpreted. Values can also differ between laboratories. Creatinine measurements can differ significantly depending on methods used. Although we have something called standardization, it can differ between methods and laboratories. So it's very important to consider using the same lab, following the same method as you are looking at your trends. Different laboratories may also use different formulas to calculate the eGFR, further complicating the comparison of eGFR measurements obtained between different laboratories. So the creatinine level must be stable when you're looking at your eGFR because our calculation itself assumes that your level of creatinine in the blood has been stable for a few days or longer. That means that it's at steady state, and it's not valid if it's changing. It is therefore not valid to look at people with the acute kidney injury phase alone and consider CKD in that setting. We have to look at trends over time. So age. There are two equations, the MDRD and the CKD epi equation, that are not valid for patients under the age of 18. As I mentioned, we do use the CKD epi equation at AMPAC. But we do have equations that can be used for children or anyone less than 18 years of age. And this is the Swartz equation. And if you need the Swartz equation, you can simply call one of our chemical pathologists and we can add that on to the requisition number. It has been used quite a lot lately for patients who need bloods done, for immigration processes, some medical aid treatment cutoffs. And of course, this is free of charge. It's just done and added to the requisition. And we have different means of interpretation depending on the age of the patient. If they're less than 2, we use different means, which we can explain to you. But if they're more than 2, we can use the general CADICO guidelines as well. And with normal aging, so your eGFR falls about 1% per annum with normal aging. So we have to keep that in mind. Older patients might have a slightly low GFR compared to the 90, 88, 89 as they age. So we need to keep that in mind when we're looking at eGFR in older patients. So what further complicates the interpretation is the non-GFR determinants. These can affect the calculation due to the effect that it has on creatinine or the analyte used in the equation. So if you look at this table, I have two analytes there. I have creatinine and I have cystatin C. And cystatin C will be one of the analytes that we talk about later. But looking at creatinine itself, we can see that body composition, as I explained, extremes of muscle mass can, depending if it's big muscle mass, can increase the creatinine and affect the EGFR calculation. If it's less muscle mass, can decrease and also affect the EGFR. The health state of the patient, chronic illness, example cancers, they can also affect the EGFR. And diet. Diet has been something that has come across to affect creatinine, and that is because we have the high protein diet, keto diets, and all these can also impact on the creatinine and therefore affect the EGFR calculation, as well as other drugs and that affect tubular handling can affect the EGFR as well. So these are the non-GFR determinants that affect the calculation. So what can be done to combat this? Well, number one, we need to look for a progressive decline in renal function over time. So as I've mentioned, repeat creatinine and EGFR is important. We can use cystatin C, as I showed you in the last slide. Cystatin C is a different biomarker of kidney function, and it is very useful to combat the non-GFR determinants. We can also look at additional indicators or renal disease markers should be sought in some patients. That is, we can look at our urine analysis, for blood and protein, our urine microalbumin levels. We also can get family history in patients with who have family history of renal disease, in patients using certain medication. Note that a significant rise in creatinine while an EGFR is more than 60 can still be very important. So when we are looking at our UNE and we're looking at our creatinine and our EGFR, we need to look at them together and we need to monitor trends. Okay, so I tried to keep that one short enough so that your creatinine did not rise from fasting and dehydration. But next, we move on to another biggie in chemical pathology. In chemical pathology, we say the liver is never an organ that suffers in silence. Sounds a lot like me. It leaks enzymes dramatically everywhere. And the key word here is dramatically. So our next question that I hear about once a month. Should I worry about an isolated increase in GGT? Clinical history in this case is, well, in every case, is always important. So we see an isolated GGT on our blood results. We shouldn't become overly concerned about it, but we do have to have some concern. So the isolated GGT or the gamma-glutamylane transpeptidase elevations are common and do not always indicate serious or progressive liver disease. No specific evaluation apart from history and physical exam is always needed. Although GGT is elevated in a number of liver conditions, in most of them, what we'll see is that the other liver enzymes are elevated as well. And these enzymes are more diagnostically useful than the GGT itself alone. So GGT, it lacks specificity. As a screening test, the GGT level is very sensitive. As I said, it's very dramatic. It drives up at anything, but it has a very low specificity. GGT is found in the highest concentrations in the liver, particularly in the biliary tubular epithelium, but also in the kidneys, seminal vesicles, pancreas, spleen, heart, and brain. Who would have thought? So elevations of this enzyme therefore can occur in a number of clinical situations, including all types of liver disease, that is, fatty liver, viral hepatitis, bile duct obstruction, and most commonly, drug reactions involving the liver. So, GGT has little clinical utility alone. The combination of high sensitivity and very low specificity seriously hampers the utility of GGT. Clinically, its value is marginal. If the other hepatic enzymes are elevated, the GGT sometimes provides little or no incremental information. GGT measurement is often used to determine if the elevations in other enzymes, like your alkaline phosphatase, come from the liver or from a non-hepatic source, like the bones or placenta. Only if ALP and GGT are both elevated, but the other enzymes are not, does the GGT then provide important utility. If both alkaline phosphatase and GGT are elevated, at least a portion of that alkaline phosphatase is of hepatobiliary origin. Conversely, if the GGT level is normal, the ALP elevation is derived from non-hepatic source, the main one a lot of the time being bone. But even in this situation, sometimes we can do other tests like isoenzymes. So when to do more? And when to do more is we're going to look at a little case. GGT has been shown to rise with alcohol consumption, and it has been used as an indirect measure of compliance with alcohol abstinence. So in this case, we have a 43-year-old female who has no significant history. She visited the GP to do what she called routine bloods. She denied drinking alcohol in excess. And doctor was very shocked to see these blood results. And he wondered what was going on. So the patient had a very elevated GGT. And as you can see, it's very disproportionate to the increase in the other enzymes. But the other enzymes are elevated in this case. So there was what to look for. If you look at the ratio of the AST to ALT in this case, it was greater than 2. Doctor had called through and we added a few more tests on this case. And what we found was very interesting. The patient had a severe hypertriglyceridemia. She had an increased IgA concentration, and the FBC showed a red cell macrocytosis, as evidenced by an increased MCV. Doctor asked if we could do a test called carbohydrate deficient transferase after having a read. We do offer this test and we were happy to add it on as well. It was increased. Doctor went back and had a good chat with the patient as well as urgent imaging, and patient did admit that she had started drinking alcohol excessively during the last year. So this is a very interesting liver case. So what are the recommendations? What do you do if your GGT is elevated but your other enzymes are normal? That is your AST, your ALT, your ALP, bilirubin, albumin, everything look normal. Well, in deciding whether to evaluate the liver further, number 1, consider the patient's risk factors for liver disease. Consider the patient's symptoms and any findings on the physical exam. Patients with risk factors for acquired liver disease like hepatitis B and C should have screening tests for these diseases. Alcohol consumption should be defined, as we saw in our previous case, and if excessive, it should be modified. In men and postmenopausal women, screening for iron overload is always appropriate, and we use serum ferritin, iron transferrin, and percent saturation for that. When you have an obese, a diabetic patient, or a patient with elevated blood lipids, they need imaging studies most probably. And lots of the time, this will reveal this will be characteristic of fatty liver disease, the ultrasound findings. Patients with hepatomegaly, splenomegaly, ascites, or any other manifestations of liver disease require further evaluation and study regardless of the GGT level. So if the patient has no risk factors, no symptoms, they have a completely normal physical examination, and they have an isolated increase in GGT, an isolated mild increase in GGT, that would be a case which most probably might not require further investigation. These patients will really benefit from add-on testing or referral, and they do not need to have the medication stopped. But you do need to discuss the abnormality with the patient and about monitoring trends if they are on treatment. And it might be a good time, as we've seen in our previous case, to inquire about alcohol consumption with the patient and to recommend moderation in its consumption. An obese patient may have fatty liver, and that is treatable with weight loss. And so in some obese patients, the need for weight reduction might be reinforced by pointing to the GGT level. So in summary, I guess we can say LFTs are a bit like a relationship statuses, complicated, easily misunderstood, and everyone might tend to overreact to a mildly raised GGT. Next, we tackle iron studies. Where ferritin lies, transferrin compensates, and CRP stands aside and watches quietly. That's how we describe it in the lab. So let's start with some basics. Iron is an essential element for transporting oxygen, DNA synthesis, and muscle metabolism. It exists in a reduced form, that is your ferrous form, Fe2, as well as an oxidized ferric form, your Fe3+. Unbound or free iron, we have to remember, is potentially toxic and could cause tissue damage due to its tendency to initiate redox reaction and create free radicals, which are damaging to the skin, the hair, and our organs as well. Therefore, the body mitigates its exposure to free iron by binding it. It also can limit dietary iron uptake and produce iron-binding proteins for its transfer in circulation and tissue storage. Circulating iron is bound to transferrin and stored in cells as ferritin. The hepatic hormone, so coming from the liver, hepcidin, controls iron metabolism by inhibiting iron release from the cells and decreasing dietary iron absorption. So the various markers that reflect the body's iron status are affected by conditions other than those related to iron deficiency or iron overload. These include gender, age, inflammation, infection, smoking, and ongoing disease processes. Therefore, no single indicator for iron status assessment exists. Iron studies should be interpreted in combination. The reference range for each parameter may differ between laboratories due to differences in the analytical methods used. Each laboratory must confirm their own reference ranges. I'm excited to say that at AMPATH, we have increased our ferritin cutoff from 15 grams per liter to 30 grams per liter. And this has been shown in studies to pick up 67% more of absolute iron deficiency. And that is huge. And you might ask, why is iron deficiency so important and need treatment? Because iron deficiency has been found to affect almost every cell and every system in the body. And it is so easily and commonly overlooked in everyday practice. It is the most common micronutrient deficiency globally, affecting 2 billion people. And this is why we have to get it right. So what are the components of our iron panel or our iron studies? Serum iron is a measure of circulating iron, most of which is bound to transferrin. Very important to remember about iron. Iron has a diurnal variation, and a decreased serum iron, therefore, is not enough to confirm iron deficiency, as iron levels may be decreased by a number of non-specific factors. Iron is also very sensitive to recent iron intake, and iron will be high if iron was taken recently, or it could be normal, and that would be a false result. We also generally, if we prefer to do iron studies fasting. If we can do it, yes, it's best to be done fasted and in the morning. And this, we have to remember that the serum iron level is low in iron deficiency and inflammatory anemia. But because it depends on efficient recycling of iron through macrophages and bone marrow, in iron deficiency, there is sometimes insufficient iron for that recycling, while in inflammatory anemia, we have increased hepcidin levels resulting in iron trapping in macrophages. So that's iron, but we have 3 other components on the iron studies. Transferrin is the main iron transport protein. So we spoke about it a bit in the physiology. Its synthesis is inversely proportional to body iron stores. Hence, levels increase in iron deficiency to facilitate iron absorption. Transferrin levels are often low in inflammatory anemia, as transferrin expression is negatively affected by cytokines. And then we have ferritin. Now, ferritin is very important. It's the main iron storage protein, and the sensitivity and specificity of the test depend largely on the cutoff values, as I've said. And we have went from 15 to 30, and this has increased specificity and sensitivity and is linked with picking up and treating greater numbers of iron deficiency, which we want to do. We want to help eradicate iron deficiency. So it is very important to note that we have found this perfect middle ground for the reference ranges, and this comes from looking at lots of studies and doing lots of research, and that's what pathologists do in the background. We read as much as we can to make sure things like our reference ranges are constantly updated to make sure that we are giving the right results with the right reference ranges always. So next, we're going to talk about the last parameter on the iron study or iron profile, and that's the transferrin saturation. This represents the proportion of serum transferrin binding sites occupied with iron itself. Transferrin saturation can rise in iron overload and fall in iron deficiency. A rise in serum iron due to dietary intake can cause a raised transferrin saturation. So this slide is telling us about the difference in some of the parameters in iron deficiency and inflammatory anemia. And another name for inflammatory anemia is functional iron deficiency. And we can see that iron is low in both iron deficiency as well as in inflammatory anemia. But your ferritin is decreased in iron deficiency. But it's important to see that it's increased in inflammatory anemia, and that is because ferritin is a positive acute phase reactant. So if there's any inflammation in the body, ferritin can raise, and it can give us a falsely high result, and we can miss iron deficiency, depending on the cutoffs we use as well. So, what is this inflammatory anemia or functional iron deficiency? This can occur in patients with sufficient iron storage reserves but who are unable to utilize these reserves adequately. Conditions leading to functional iron deficiency include acute and chronic infectious diseases like HIV, inflammation, or malignancy. Absolute and functional iron deficiency can even occur simultaneously. And functional iron deficiency contributes to iron deficiency because of impaired iron absorption from the gut. The inflammatory cytokines that are found in inflammation stimulate the hormone we talked about before called hepcidin, which decreases iron absorption from the gut and impedes iron mobility from macrophages and hepatocytes. So, what do we do when we're thinking about an inflammatory anemia? Well, we have other parameters that can tell us that there is inflammation going on, and one of those are CRP. And if your CRP is above 10 and it's high, that can be an indication that perhaps your ferritin is falsely elevated. So it is very important, as I say, to look at your patient as a whole using your clinical history, your physical examination findings, as well as your blood tests altogether. Low iron, as I've mentioned, cannot be interpreted in isolation, and it should not be what we say the patient has iron deficiency only based on, because we can find low iron in infection, inflammation, and malignancy. We need to look at our ferritin values and we need to compare them to proper reference ranges. Transferrin and transferrin saturation can also be important. Transferrin saturation alone as well is also poorly specific in conditions like pregnancy or patients on contraceptives and also in chronic illness. And we can sometimes see a low transferrin without an absolute iron deficiency. So in patients with chronic inflammatory conditions, interpretation of the iron profile must be done cautiously. Any clinical or laboratory evidence for an active inflammation state should prompt further investigation for iron deficiency. And we need to look at that serum ferritin cutoff using maybe different cutoffs. And when we have an elevated CRP, we sometimes look at higher cutoffs, even up to 100. We also need to consider other conditions or inflammatory states that are present. And these are things like chronic kidney disease, heart failure. They also have different specific cutoffs, but always feel free to have a chat to your local hematologist or chemical pathologist about your patient, where we can get a good full clinical picture and look at laboratory results and discuss together. So this is a picture of the absolute iron deficiency versus the functional iron deficiency, and we can see that in functional iron deficiency sometimes even have normal blood iron stores, but mobilization of the iron is the problem. But in absolute, we have low body iron stores and total iron available is inadequate. So one other test that's not in the iron profile that I wanted to talk about is the soluble transferrin receptor, which is offered by us, and it can be used when we are evaluating patients who may have inflammation, infection, or chronic disease, or in other conditions in which you suspect that the ferritin concentration is not actually correlating with the iron status of your patient. The concentration of the soluble transferrin receptor is a good indicator of iron status. Iron deficiency causes an overexpression of the transferrin receptor and serum transferrin receptor levels. While ferritin is, as we've said, the accepted method for assessment of iron deficiency, Bear in mind, as I've said before, it's an acute phase reactant and will elevate in response to processes that do not correlate with iron status. So the serum soluble transferrin receptor is not an acute phase reactant, and the interpretation of iron status using this is not affected by those confounding pathologies. So it is inversely related to iron status, and it elevates in response to iron deficiency and decreases in response to iron depletion. So this is a lovely table. It's from one of our AMPAT chats. So these are lovely little chats that have just amazing snippets of information, and they're freely available on our website. You can download them and have a look. They are absolutely interesting and very good to use in everyday practice as well. So should we ever be cautioned even in using the soluble transferrin receptor? So it should not be used in routine clinical evaluation of patients. For that, we have our iron panel and we have our ferritin, which is part of the iron panel. That's perfectly enough. It can be used when the picture is confusing and more is needed. We should not use it in patients with hemolysis and recent blood loss, because here we can get falsely elevated results, as well as in patients with thalassemia and sickle cell disease. Okay, so that's iron. Moving on to the lipid profile. So in chemistry, the lipid profile has been described as a family meeting, like the ones that Cyril Ramaphosa used to have with us, where LDL causes problems and HDL tries to fix them. So the big question that I get a lot, and it's not only from clinicians, it's also from patients, it's from family, it's from lab staff, it's from everyone, is to fast or not to fast. So what are we talking about? We're talking about a fasted lipid profile. So our serum lipid profile is measured daily, and it's measured in many, many patients. It's used for cardiovascular risk prediction, and it's now become almost, I can say, a routine test at times. The test has 4 basic parameters: the total cholesterol, HDL cholesterol, the good one, LDL cholesterol, the bad guy, and triglycerides. We also do report the non-HDL cholesterol, which is being used more and more. So it's usually or traditionally or previously been done on a fasting blood specimen. Everybody knows, go to your doctor, you want to do cholesterol. He says, okay, you can go tomorrow. Let's do an 8 to 12 night overnight fast. Complete that, don't eat anything, and test in the morning. And it's the exception, of course, generally water and medication can be taken. So should we be doing it on a fasting profile only, and why? Well, we used to fast because it does happen that your postprandial triglycerides remained elevated for several hours. And previously, it was believed that most of the reference ranges for serum lipids were established on fasting blood specimens. So those were the big 2 things on why fasting was always recommended. The fasting state is basically essential, we're saying, for the triglyceride estimation, because the triglycerides are the ones that remain high for several hours after a meal. And the Friedewald equation used for LDL calculation can be affected by high triglycerides. So that calculation is LDL cholesterol equals total cholesterol minus HDL minus triglycerides over 2.2, because we report in millimoles per liter. And the problem comes in when you have a triglyceride that's very high, that's more than 4.5, and you can't use this equation. So basically this is telling us that LDL is a calculated parameter. And how can we overcome this? Have we overcome this? Yes. So we now offer direct LDL. So instead of using a calculation to get LDL, we actually measure LDL and we tell you your measured LDL result. So this is why we don't always need to do fasting specimens anymore. Number one is because we are now measuring your LDL. We do direct LDL measurement. AMPAC, our reference ranges have seen to be holding true for fasting or non-fasting specimens as well. So, the thing with us is we consume several meals during the day. And the truth is, the postprandial state is actually what dominates our life. I mean, most people, even celebrations, everything is always around, it's always about meals and what we're eating and what we're doing. But still, nevertheless, we've always done fasting bloods for the lipid profile, and those were because of the reasons I told you. But we are moving away from only doing fasting bloods now, and we can do our non-fasted lipid profiles. They should be freely available. Why? Because we have improved patient compliance with lipid tested when it's recommended that non-fasting lipid profiles are done. I'll tell you why. The patient will come through to the rooms, have all the bloods ordered, and then they'll go straight to the lab for testing. But sometimes when you ask a patient to fast, they might actually never go through the next day to the lab or the following week. We have decreased compliance when being asked to fast. And fasting can be a barrier. I mean, really, I have a 5-year-old. I am not going to be able to get my 5-year-old to fast. It's very unpopular with children. It also is hard to do population screening when you need fasting as part of this, and it's often unsuitable for some patients, like patients with diabetes and patients who can't fast for long periods of time. Non-fasting tests can also used to assess other metabolic disorders. So it's not that the HbA1c needs to be fasted, and we might have a UNE done, and so we can just do all the tests together, and it can be much easier. So in summary, what does the chemical pathologist have to say? Always, let's correlate clinically. But the best chemical pathologist knows when results are impossible, but they also know when humans are impossible too. I hope that everyone has enjoyed this talk and taken little snippets from it. And we now will go to take some questions because we have some time as well.
Thank you, Dr. Reddy. That was a most insightful and highly practical presentation, and I'm sure everyone will agree that the topics you've covered are directly relevant to our day-to-day clinical practice. We will now go to the Q&A session, and I would like to extend an invitation to the rest of my panel to contribute as you see fit. So, Dr. Reddy, you've mentioned that EGFR can be inaccurate at extreme body habitus. In your view, should we be using cystatin C more routinely in obese or elderly patients?
So I would say not routinely. It can be very useful, especially as I mentioned, when the creatinine-based estimates are suspected to be misleading, or when the clinical findings do not correlate with the EGFR. And I think that we should use it for those specific patients, and it's quite easy to do because if we've ordered a normal UNE with the creatinine-based EGFR and we think this is not in keeping with our patient, we can actually simply add on the cystatin C-based GFR on the same requisition, and we will get then the cystatin C-based GFR plus the combination creatinine cystatin C GFR, which has shown to be even more useful and have an even better sensitivity and specificity. So even with the obese patients, we still use the the creatinine based estimates, as sometimes the cystatin C in this case can also be misleading.
It seems like EGFR is quite a bugbear for everybody, because the other question is, given that EGFR naturally declines with age, how can clinicians practically distinguish between normal aging and early chronic kidney disease?
So I think it was something that I was stressing. It was looking at trends over time, looking at the trend. And I'm sure with many of the clinicians who've used our lab, they would notice that when we report the urea and creatinine and the EGFR in the cumulative report, we always have the trends, as well as in the individual report we have a table and we have the results so that they can see the trend over time. You would also need to look for additional evidence of kidney disease in these patients. As per the KDIGO guidelines, we need to look for microalbuminuria, and we can also look for, on the physical exam and history, we can look for hypertension, diabetes. So we have to always bear in mind our physical exam, our clinical history as well before we go to our blood tests.
So, Dr. Reddy, then you would recommend that laboratories routinely report creatinine trends alongside EGFR to improve clinical interpretation?
Yes, definitely. I think because even if it's a small but significant rise in creatinine, we can overlook it if we're not able to see the trend and we're not able to see what was happening before. Sometimes the EGFR can remain high, but the creatinine is actually the one that's changing so rapidly. So I definitely think we need to have trends on all our reports, and we do at AMPATH.
Thank you, Dr. Reddy. So with regards to our liver disease and alcohol consumption, metabolic disease and alcohol abuse is a very rife conditions that one finds in our population. So can an isolated gamma GT elevation serve as an early marker of metabolic syndrome or non-alcoholic fatty liver disease?
It can. So we can see it sometimes associated with obesity, insulin resistance, and sometimes fatty liver disease and cardiometabolic risk factors. But like I said, the main thing is that we would see these things on the clinical exam. We'd see the insulin resistance on the bloods, and we'd be able to tell that there would be more information linked to that isolated GGT. So there would be other things.
So I think one of the other aspects with regards to alcohol abuse and alcohol cessation is a very important aspect of interpretation of gamma GT levels. Is there a reasonable time frame in which clinicians can expect gamma GT levels to normalize after alcohol cessation?
So typically from the literature, we say between 2 to 6 weeks. So we should repeat, I would say, to go on, the longer time period, at least, about 6 weeks. And it also depends on the baseline elevation and if there's ongoing liver injury from other causes as well.
Okay. So the next, I think, common aspect in chemical pathology that we often see, and I'm sure my fellow hematologists would agree, is iron deficiency. And one of the questions here is, in the context of inflammation, at what ferritin level would you still strongly suspect underlying iron deficiency?
So in inflammatory states, I generally use a level of 100, and I would say anything below 100, depending on that CRP and that rise in the CRP and how rife the infection is, it may still indicate iron deficiency. But it really does also depend on the clinical context and how high the CRP is, how rife the inflammation is.
Do you recommend routinely adding a CRP when interpreting iron studies, especially in hospitalized patients?
So we did look at this and we tried to look at the literature because it's actually a question we get quite a lot. And yes, CRP can be extremely helpful because it provides context for the ferritin interpretation and it helps to distinguish inflammatory-related changes. But I don't think we should just do it routinely because none of the studies say just do it routinely. I think we should do it when we suspect that this is actually not the ferritin level of this patient. This is not in keeping with what I expect. There's something else going on.
Do you believe that soluble transferrin receptors should be more frequently used in clinical practice, especially when one has really complex cases when trying to decipher an iron study profile?
I think that the soluble transferrin receptor, and I mentioned it as well, is very valuable in the selected complex patients. Remember, we're always taking into we're always worried about cost and availability of things, and that is always something that can limit routine use of things. So I think in our uncomplicated patients, the iron profile is more than enough. And the important thing is that, it's called iron deficiency. So everybody thinks we need to look at the iron, but the truth is we need to look at the ferritin, because the ferritin is telling us about the body's iron stores. And the ferritin is a marker that is going to tell us about iron deficiency. And therefore, I think ferritin remains adequate in the uncomplicated cases, and soluble transferrin receptor should be reserved for those complex cases.
Okay, so what we're essentially saying is that ferritin is the main player of the iron profile.
Yeah.
So we're talking about the lipid profile. With growing acceptance of the non-fasting lipid profiles, are there any specific high-risk patient groups that a fasting lipid profile would still be preferable?
Yes, I think when you are expecting your triglycerides to be elevated and you're worried about pancreatitis, or your treatment decisions really rely, on an extremely, tight LDL. So then those are the ones that you might say, okay, you've had a previous high triglycerides, you're at risk, you should fast. But I think in general, for most of the other patients, the normal patients coming through for your screens, your diabetics, your hypertensives, they don't have to fast. They can do their bloods. And if we do see that, okay, we didn't expect, but this patient has a very high triglycerides, we can always then repeat the test fasted.
Thank you for that, Dr. Reddy. I think one of the final few questions remain. So do you foresee laboratories moving more towards direct LDL measurement as a routine standard, or do you think we're still going to continue with the Friedewald equation evaluation of LDL?
So I definitely think everybody should be, doing the direct LDL, and we can see in the presentation why it's so important. And with more patients going through and having non-fasting bloods done, really we do need to start measuring. And as I said, in Empath, we have been measuring LDL, and we have been providing those values for a while. So, yeah.
Thank you, Dr. Reddy. I think just one or two remaining questions. Do you think urine creatinine albumin should be collected first in your first morning void of urine?
Yes, so I think if you're doing a spot urine creatinine albumin, that would be a good time to collect.
And with regards to a question from the chat, do we treat anemia from inflammation, or should we treat the inflammation primarily?
So I would think we start with treating our inflammation before we go, and it obviously depends on the clinical context as well. What is the inflammation from, and what is the level of the ferritin? Clinically, is the patient having signs and symptoms? And maybe one of the hematologists want to weigh in. I'm not sure.
Yes, I can come in there. I'm Dr. Renette Weyers. I'm one of the hematologists at AMPATH. And when it comes to anemia per se is one can almost call it a symptom. It's not a diagnostic entity in itself, and it's always related to underlying pathology. So the question is here, the issue here is if you don't treat the underlying cause of the anemia, whether it be a nutritional deficiency, inflammation, bleeding, etc., you're not going to win, and the anemia is not going to be addressed. So the first starting point would be to address the inflammation. Otherwise, the source or the cause of the anemia won't be addressed. And then depending on your patient's clinical context, of course, whether you need symptomatic relief from the symptoms of the anemia, how severe the anemia is, and if there are other concurrent contributing factors, for instance, bleeding or a concurrent nutritional deficiency, that needs to be addressed. But yes, the anemia won't resolve unless you treat the underlying cause.
Thank you, Dr. Weyers. I'd like to conclude this very first session of our General Practitioner Masterclass webinar series. Thank you, Dr. Reddy, for that very insightful presentation. And thank you to the rest of my panelists for sacrificing your evening to contribute to this session. I would like to wish you all a very good evening ahead, and we will see you at the next session. Thank you very much and good night.
Thank you. Good night.